Ever wondered what a solitary pulmonary nodule is? It's a round or oval, sharply circumscribed radiographic lesion, up to 3 to 4 centimeters in size. It may or may not be calcified and is surrounded by normal lung tissue. This nodule can be benign or malignant. Understanding the nature of a solitary pulmonary nodule is crucial, as it helps guide further diagnostic and therapeutic decisions. So that's your first insight into what a solitary pulmonary nodule is. But what makes it benign or malignant? Let's delve deeper. Before we proceed, it's crucial to understand some terminology. When we talk about solitary pulmonary nodules, we're essentially referring to a round or oval, sharply circumscribed radiographic lesion that is up to 3 to 4 centimeters in size. This lesion may or may not be calcified and is surrounded by normal lung tissue. Now, when we say nodule, we're talking about a lesion that is smaller than 3 centimeters. Anything bigger than 3 centimeters we refer to as a mass. These terms are not just about size, but they also carry implications about the potential nature of the lesion. For instance, a nodule might be benign or malignant, implying it could either be a non-cancerous growth or a cancerous one. Now that we understand these terms, we can explore the differential diagnosis for a solitary pulmonary nodule. So, how do we determine if a solitary pulmonary nodule is benign or malignant? This is where differential diagnosis comes into play. 70% of solitary nodules are benign, while 30% are malignant. Benign nodules can be caused by a variety of factors. Infectious granuloma, for example, is often the result of histoplasmosis, coccidiomycosis, TB, or atypical mycobacteria. Other infections, such as bacterial abscess, PCP, or aspergilloma, can also lead to benign nodules. Furthermore, benign neoplasms like hamartoma, lipoma, and fibroma, as well as vascular conditions like AV malformation and pulmonary varix, can cause benign nodules. On the flip side, malignant nodules are typically due to bronchogenic carcinoma, adenocarcinoma, squamous cell carcinoma, large cell carcinoma, or small cell carcinoma. Metastatic lesions from the breast, head and neck, melanoma, colon, kidney, sarcoma, germ cell tumors, and pulmonary carcinoid can also lead to malignant nodules. It's important to remember that these are just possibilities. The actual cause of a solitary nodule could be one of these or something else entirely, which is why further testing is crucial. Understanding the differential diagnosis is key in determining the treatment approach. But what about specific types of neoplasms? Let's take a closer look at 2 specific types of neoplasms: carcinoids and hamartomas. Carcinoids, typically emerging in individuals aged 40 to 60, are most often located centrally and may produce symptoms and signs of bronchial obstruction. Hemoptysis, or coughing up blood, is present in around half of all cases. On the other hand, hamartomas, which account for 10% of benign lung lesions, are composed of tissues normally present in the lung, such as fat, epithelium, fibrous tissue, and cartilage. However, these tissues exhibit disorganized growth. Hamartomas are more common in men and peak in incidence at around age 60. Unlike carcinoids, they are usually peripheral and clinically silent. A chest X-ray of a hamartoma may reveal a clustered popcorn pattern of calcification, which is pathognomonic or indicative for this type of neoplasm. These are just 2 examples of the many possible causes of solitary pulmonary nodules, each with its unique characteristics and implications. We've covered a lot today, from the basics of solitary pulmonary nodules to specific neoplasms, from defining what a nodule is to differentiating between benign and malignant nodules. We've delved into the terminology, understanding the difference between a nodule and a mass. We've also explored the differential diagnosis, distinguishing between various types of benign and malignant solitary nodules. We further examined the characteristics of carcinoids and hamartomas and how pulmonary neoplasms may present themselves. This knowledge is crucial, not just for medical students but for every healthcare professional. It's these bits of information that can make a world of difference in diagnosing and treating patients effectively. Stay curious, keep asking questions, and remember, the more you learn, the better prepared you'll be to make a difference in the world of healthcare. If you found this video helpful, don't forget to subscribe and give us a thumbs up. Thanks for watching. Let's take a deeper dive into a specific sign that is associated with malignancy: the corona radiata sign on chest CT. This sign is characterized by fine striations that extend linearly from a nodule, creating a spiculated or spiked appearance. The corona radiata sign is a vital indicator in diagnosing malignancy. When present, it can be a red flag, suggesting the need for further diagnostic tests. Some of the investigations associated with this sign include a comparison with previous chest X-rays or CXRs, kinetic densitometry, contrast-enhanced CT of the thorax, sputum cytology, a biopsy, watchful waiting, and even a PET scan. Understanding the characteristics of a benign versus a malignant solitary nodule on a CXR is crucial. For instance, benign nodules are typically smooth and well-defined, whereas malignant nodules often show irregular or spiculated margins, possibly accompanied by the corona radiata sign. Remember, understanding the corona radiata sign and its implications can greatly aid in the diagnosis and treatment of malignant nodules. It's another piece of the puzzle in our quest to understand and effectively treat solitary pulmonary nodules.